Continuing with chapter 30, going on to reassessment. So it's obviously very important to repeat the primary assessment, even more important to reassess your vital signs because of that late progression of a lot of abdominal injuries. Interventions, aggressive treatment for shock, and covering wounds as necessary. If an evisceration is found, you want to place a saline moistened dressing over the wound and transport. We're never pushing any of that back in. If a patient has a ruptured diaphragm, we're going to want to give them positive pressure ventilation because they're going to be breathing inadequately, unfortunately. And then be very thorough in your communication to the hospital. You want to, again, make sure that you paint that picture so that they have an idea of what the scene looked like, since you'll be the only one giving that to them. When you have a patient that's trying to refuse transport after sustaining an injury to the abdomen or GI system, try and talk them through it a little bit more, give them some detail to try and let them know that there's a huge risk for complications, but making sure to let them know if they decide not to be transported, that they can always call back later and encourage them to do so. So emergency care specific abdominal injuries closed. The biggest concern for us as pre-hospital care providers when dealing with abdominal injuries is we just truly will never know the extent of the injury inside. So we have to transport. They need to have a more thorough evaluation to determine the severity of their injuries. Make sure that you put them in a position of comfort, high flow to if there's any signs of shock, and then treat for that shock otherwise. A patient with a blunt abdominal injury is more than likely going to need a backboard. So if they have like severe bruising to the abdominal wall, a liver or spleen laceration, rupture of an intestine, tears in the mesentery, rupture of the kidneys, avulsion of the kidneys, severe intra-abdominal hemorrhage, or peritoneal irritation and inflammation, we want to make sure that we transport quickly while protecting the spine, continuing to monitor vital signs, but trying not to move them around too much is going to be helpful in trying to prevent the bleeding from picking up. Anytime that you start up in that heart rate when somebody is bleeding internally, the faster they're going to bleed. Open abdominal injuries, try and maintain a very high index of suspicion for unseen blood loss. We've talked about that a couple of times now. Only a surgeon is going to actually be able to accurately assess the damage. If any object has penetrated the peritoneum, just assume that there are injured organs in there. Inspect a patient's back and sides for any of your exit wounds or any additional penetration wounds, because like we talked about with stab wounds or gunshots, they know that they've been injured, but they may not understand how many times that they were injured. Apply dry sterile dressings to all open wounds. And then if the penetrating object is still in, make sure that you stabilize it. We're not going to be taking anything out. Evisceration, you do see a little bit of a picture there. We are not putting anything back in. So cover it with a moistened sterile dressing, secure with dressing with a bandage, and then secure the bandage with tape. So just continuing to cover it over. For the genitourinary system, genitourinary system controls both reproductive control plus waste discharge. Sorry. Organs are located in the abdomen as well as the pelvis. You've got several different structures, and we'll have a picture next. Your male genitalia obviously lie outside of the pelvic cavity, where the female genitalia are more protective within the pelvic cavity. Here's an overall picture representation of all of the different organs. Here's the male, and here's the female. You can kind of see how it's seated within the pelvic cavity. Specific injuries, kidney injuries, they're not unusual and they don't tend to occur by themselves. It takes generally a pretty forceful blow, which can damage everything around. If you have less significant injuries, they can be from an indirect blow, like a football tackle, etc., that kind of jostles everything around in there. You want to suspect kidney damage if your patient has any of the following. So an abrasion, laceration, or contusion on the flank, that's kind of the back of your side. Any sort of penetrating wound in the region of the lower rib cage and above the flank or the upper abdomen, because it can travel straight through. Fractures on either side of the lower rib cage or the lower thoracic or upper lumbar vertebrae. That means a significant force has been applied there. And then a hematoma in that flank region. Bladder injuries may result in a rupture, which then you end up having urine spilling around. And urine has a lot of different components to it, but uric acid is definitely one of the bigger components for things that are dissolved within urine itself. If the bladder is full, it definitely increases the chance for bladder rupture. Penetrating wounds to the lower mid-abdomen or the perineum can also directly involve the bladder. In males, sudden deceleration from motor vehicle crashes can shear the bladder from the urethra. Because there's not everything packed in there really, really tight like it is in the female anatomy. And then late trimester of pregnancy, bladder injuries increase because you've got this uterus in there that has massive amounts of weight to it. And so that's going to affect the bladder more. So you can also have pieces from a fractured pelvis that can actually go and penetrate into the bladder itself. External metagenitalia injuries. You can have soft tissue wounds. There's not a whole lot of bony components there. So it's mostly going to be bruising, tearing of muscles, etc. They're extremely painful, and oftentimes the patient gets really worked up about it, but they are very rarely life-threatening, and we don't give priority to genitalia over more severe wounds unless there's very, very, very significant bleeding. Then that's a little bit different, but it's uncommon for there to be that significant of bleeding. For female genitalia injuries, you have the internal structures, the uterus, ovaries, fallopian tubes. They're rarely damaged because they're relatively small, they're pretty deep down into the pelvis, and they're well protected. However, when a woman is pregnant, her uterus ends up enlarging, obviously rises well out of the pelvis. So you can have injuries that can be extremely serious. The uterus has a very, very rich blood supply during pregnancy. And then, of course, you have the fetus to keep in mind as well. In the last trimester of pregnancy, the uterus is also very large and can obstruct the vena cava. So even when you don't have an injury directly to the uterus, the fetus, etc., if you lay that pregnant female on her back to get her on a backboard, etc., that can actually cause a massive drop in her blood pressure. So you want to make sure that you can put her on a backboard, but tilt it over to that left side so that the uterus isn't laying straight back on that inferior vena cava. External genitalia, very rich in nerve supply, so injuries are very, very uh, painful. You may get vaginal bleeding because of penetrating or blunt trauma. Whenever you're dealing with a female, 9 to 99, obviously you're going to always suspect or question about pregnancy, and it's until ruled out. So we want to talk about their last known period, ask about their sexual history as is relevant. Assume that all women of childbearing age are possibly pregnant. In case of external bleeding, you want to put a sterile pad outside of. We never pack the vagina at all because that can cause further damage. We don't use tampons in the case of trauma because we don't want to cause further injury, and we're not doing a full out assessment. So we just err on the side of caution and just use a sanitary pad externally. When you're assessing a patient, be professional, provide for privacy. If it's at all possible, keep the same gender person trying to assess that patient. Make sure that you look for blood on underwear because it might give you some clues as to what's going on. And we only inspect the external genitalia. And then you don't need to do that for everybody. If there are complaints of pain, external signs of injury, or a mechanism of injury that's congruent with possible genitourinary injury, then go ahead and assess that. But it's not a necessary thing. Yes, it is in your head to toe just to make sure you don't miss it. But if there's no reason to look, you don't look. Scene size up. This is pretty similar to everything else. Just know that you may want to throw on some eye protection. Blood can be hidden under very thick layers of clothing, so you may want to have that little bit of extra protection. Look for your MOI. Your patient may not be forthcoming with what's going on because they're embarrassed or because they're worried that you may do a physical exam and they don't want you all up in their business. So if they don't have a story that fits, they may have made up a different MOI because the one that actually happened is pretty embarrassing. So make sure that you're looking into that a little bit further, making sure their story matches up with their MOI. And if it doesn't, be professional about it. Say, hey, something's not quite adding up here for me. Can you just explain it to me a little bit more? And give them the opportunity to correct the story. We're going to go ahead and stop here, and we will continue on in the next video.